തുടങ്ങിയിട്ടില്ല. സാറ് വായിച്ചിരുന്നു. 2
இதுல எப்படி பேக்ரவுண்ட் ஆட் பண்றது? இதுல பேக்ரவுண்ட்
Shall I confirm the participants for the UG paper session 11, UG paper 1, UG paper 01, UG paper 02.
Present, ma'am. Present, ma'am.
Yeah, noted. UG paper 03.
Present, ma'am.
Noted. UG paper 04.
Present, ma'am.
Noted. UG paper 05, UG paper 05, UG paper 06, UG paper 06, UG paper 07, UG paper 07, UG paper 08, UG paper 08, UG paper 09, UG paper 09, UG paper 10, UG paper 10, UG paper 10, UG paper 11, UG paper 11, UG paper 12, UG paper 12, UG paper 13,
Yes, ma'am.
UG paper 14, UG paper 14, Del, can you please rename your identity with your code number, please? All, please rename yourself with your code number. Pushpagiri College of Dental Sciences is delighted to host the Kerala State 5th Annual Triple Conclave. Let us start the scientific presentation for today under the Department of Oral and Maxillofacial Pathology with undergraduate paper presentation, session 11, hall 3. We invite the judges for the session, Dr. Tibin K. Baby, reader, Department of Oral and Maxillofacial Pathology, Pushpagiri College of Dental Sciences. We invite you, ma'am. and Dr. Rekha VR, Reader, Nurul Islam College of Dental Sciences and Research Center, Thiruvananthapuram. We invite you, ma'am.
Hi.
Now let me give the instructions for the paper presentation. The time for your presentation is 5 minutes. You will be getting the first ring or the first instruction at the end of the 4th minute. And at the end of the 5th minute, you are supposed to wind it up. 2 minutes will be given for the discussion part. You will be getting 30 seconds to share your screen. If you're not able to share your screen, your chance will be going to the end of the session. I hope the instructions are clear. Now, let us start the session. UG paper 01, UG paper 01. UG paper 01, UG paper 02, UG paper 02.
A very good afternoon, ma'am.
Yeah, kindly start sharing your screen.
Am I visible, ma'am? I'm Madhumita, here to share my case report on spindle cell carcinoma. Introduction: spindle cell carcinoma, otherwise called as sarcomatous carcinoma, is an uncommon biphasic aggressive neoplasm exhibiting high mortality rate. The WHO recognizes spindle cell carcinoma as a variant of squamous cell carcinoma and includes the term sarcomatous squamous cell carcinoma. It comprises less than 1% of all oral cavity tumors and it belongs to a rare entity. In our institution, we reported a case of a female patient. I'm here going to present the case report of our case. Female patient, age 72 years, presented with a chief complaint of ulcer in the right lower back tooth region for past 1 month. The pain was continuous and it was aggravated on mastigation. The patient also had a history of hypertension and wheezing for past 3 years and she was under medication. So the patient did not have a history of pre-existing squamous cell carcinoma, or she didn't underwent any radiation therapy, or she don't have any oral habits history. Extraoral examination, there was no facial asymmetry present and there was no extraoral swelling or growth present, and there are also no sinus or fistula present. Intraoral examination revealed on inspection the lesion revealed a ulceroproliferative growth in the right lower back tooth region, which was grayish white in color with pigmentation in the buccal mucosa and lower lip. The ulcer was measuring about 3 into 2 centimeter and it was oval in shape. On palpation, it was tender and firm in consistency, and there was no lymph node involvement. So, professional diagnosis what we gave was malignant ulcer seen in the right buccal region. Differential diagnosis was made as ulcer secondary to deep fungal infection. And the radiographic examination, we asked them, we advised OPG. So OPG reveals deep proximal forehead with lytic areas of bone destruction noted on the periapical region of forehead with permeative pattern along with the resorption of the mesial and distal root apex. Here comes the histopathological findings. The histopathological finding shows the stratified squamous epithelium with a neoplasm arising from it and infiltrating the subepithelial tissues in sheets and fascicles. So the tumor cells are predominantly spindle shaped and focally epithelial. There was high nucleus cytoplasmic ratio and highly pleomorphic mitotically active nuclei with condensed chromatin and conspicuous nuclei was present. This desmoplasia and dense infiltration by lymphocytes, neutrophils, plasma cells, etc. And our histopathologic
Ma'am, you're not audible. UG paper 02. Are you here? UG paper 02 will give you a chance at the end. Next, I would like to call UG paper 03.
Good
UG
afternoon,
paper
ma'am.
03.
Yes, ma'am.
You
Present here.
can share your screen.
Yes, ma'am. Is my screen visible, ma'am? Ma'am?
Your time starts now.
Ma'am, is my screen visible, ma'am?
Yeah, now it's visible.
Okay, ma'am. Thank you. Good afternoon to one all present here. This is a clinical, epidemiological, and histopathological study of oral squamous cell carcinoma over a period of 10 years. This is an institutional-based retrospective study. So, table of contents. First, we'll be talking about the objectives, research methodology, and result analysis and conclusion. So, as introduction, squamous cell carcinoma is the most common. The common sites are tongue, lips, floor of the mouth, and buccal mucosa. And the common etiology goes by the mnemonics 4S, that's spirit, smoking, sharp tooth, and spicy food. Research objective. So the aim of the study is to understand the correlation and significance between habits, sex, site of the lesion in an institution, in a private institution in Coimbatore over a period of 10 years. Methodology. All diagnosed oral cell squamous cell carcinoma from the year 2012 to 2022 were reviewed, including histological analysis and review of demographic and clinical information as well. Inclusion criteria, oral squamous cell carcinoma which were diagnosed and confirmed histopathologically, and the sample size taken was 119. Exclusion criteria were cases which weren't confirmed histopathologically. Result analysis, all analyses were conducted using SPS, using the app, and we also used chi-square method to find the association between habits and site of lesion. So age distribution, a majority of the population was between the age group of 51 to 60 years, followed by 61 to 70 years, and then we had people from fourth decade and people above 70 years. So this was the age demographic distribution. Next one, looking at the sex ratio, 63% of males were affected with squamous cell carcinoma and 36% were female. Excuse me, ma'am. Habits. So regarding the habits, we didn't have proper data for the habits, but whichever were mentioned, there is pan chewing, tobacco chewing, betel nut chewing, areca nut chewing were smokeless forms of tobacco, which were more commonly used, about 23%, and about 7% of people used smoking form of tobacco, such as BD and cigarette. About the rest population had been using alcohol or other forms of etiology, such as sharp denture or sharp cusp or any irritations. Looking at the site of the lesion, majority of the lesions were found in the alveolus region, followed by lateral border of tongue, followed by buccal mucosa, and then palate and floor of the mouth. And posterior part of the tongue where had the least number of cases. So clinical diagnosis, clinical diagnosis, the most given clinical diagnosis was carcinoma of alveolus, followed by carcinoma of buccal mucosa, tongue, and followed by ulceroproliferative lesion. Traumatic ulcer and salivary gland tumor were also equally given. So looking at the histopathological diagnosis, about 87% of the cases were well differentiated, 11% were moderately differentiated, and the rest were low-grade carcinomas. So these are the references. I would like to conclude that oral squamous cell carcinoma is asymptomatic in a lot of cases, but as dentists, it's important for us to do the oral screening and do the gold standard test of histopathology to confirm and to spread awareness about the same, and also ensure people quit ma'am. Okay. So it is also important as dentists to do oral screening and do confirmatory gold standard test of histological to confirm the oral squamous cell carcinoma. And it is of utmost importance that we also spread awareness about the ill effects of alcohol, smoking, and betel nut chewing. With that, I would like to end my presentation, ma'am.
It was a good presentation. So yours was a retrospective study, right?
Yes, ma'am.
Okay. Which location, which age group was most affected?
From the most effective age groups were in the 5th decade of life, ma'am, 51 to 6 years, followed by
what will be the reason? What will be the reason?
Ma'am, a lot of people had history of had habit history for the over 10 to 20 years, ma'am. So that is one possible etiology, ma'am.
Was it tobacco chewing or any other?
Yes, ma'am. Ma'am, tobacco chewing, forms of tobacco, ma'am, betel nut chewing, areca nut chewing, pan chewing, Hans, Zarda, these were the common things that people came up with the history of.
Okay. Okay.
Over to Dr. Steven.
Yeah, it was a good presentation, but I just want to know your shown in your the percentage of you had a good percentage in young adults in your squamous cell carcinoma, correct?
Yes, ma'am. Good.
And also you showed that the etiological factor, which is maximum with non-smokers, correct?
Ma'am, actually, non-smokers, we were not able
no
to...
association with smoking, no association with tobacco, right?
Ma'am, actually, there's a area of benefit of doubt, ma'am, because a couple of cases, history weren't mentioned. So we considered those as no use of tobacco because we couldn't associate with tobacco usage. So that was one thing that we were, that was in the area of gray, ma'am.
So what do you think, what do you see it in young adults?
Young adults, oral squamous cell carcinoma is also associated with other predisposing factors, human papillomavirus or alcoholism, which we were unaware of the patient's history. So possible causes are other predisposing factors, ma'am.
Okay, thank you.
Thank you, judges. Now I would like to call UG paper.
Present, ma'am.
04.
ஃபாஸ்டா முடிச்சிடுறாங்க அவ்வளவுதான். ஏதாவது கொஸ்டின் கேட்பாங்க. பரவாயில்ல, ஆப்சென்ட் போட போடட்டும். பாப்பா டென்ஷன் இந்த பக்கமும் வச்சுக்கிட்டு அந்த பக்கமும் வச்சுக்கிட்டு. சரி, நான் சொல்றதை கேளு. Patient has got mucinous clinical
Ma'am, is my screen visible?
high metastasis, early metastasis.
Yes, yes. Can start now.
Good afternoon, everyone. Today I'm going to present a case on mixed infection comprising of mucormycosis, actinomycosis, and candidiasis leading to maxillary osteomyelitis in a diabetic mellitus patient in post-COVID phase, the first case report. In 2021, a 70-year-old male reported with the chief complaint of pain in right maxillary region for 3 months and passage of content from oral cavity into the nose. The patient complained of pain and also noticed the denuded bone over the right maxillary alveolar ridge region. He further told us that he suffered from fever 4 months ago and was diagnosed with COVID-19 infection for which he was hospitalized. During treatment, he received steroids along with other drugs such as remdesivir, tocilizumab, and ivermectin. He further told us that he is a known case of type 2 diabetes mellitus for last 20 years and was on oral hypoglycemic drug metformin 1000 mg twice daily. An intraoral examination revealed missing teeth in relation to 1.2 to 1.7 and denuded mucosa exposing the necrotic yellow-colored bone. An oroentral opening was also noticed on the palatal side of the necrotic alveolar bone. Based on our clinical findings, we advised patient for the radiographic examination and the paranasal sinus view showed haziness in the right maxillary sinus region. Now, based on our clinical and the radiographical examination, a provisional diagnosis of osteomyelitis of maxilla secondary to the mucormycosis was given. Other differential diagnoses included deep fungal infections, malignant neoplasms, etc. Now, based on our provisional diagnosis, we advised patient to undergo sequestrectomy. Before operating, the patient was checked for his blood sugar levels. His fasting blood sugar level was 90 milligram per deciliter on the day of the surgery. Sequestrectomy was done for the dead right maxillary dentoalveolar segment along with the curettage for right maxillary antrum and nasal floor. As seen in the picture, the tissue obtained was dead, necrotic, and black discoloration gave us a strong evidence of mucormycosis. Now, the tissue obtained was further sent for the histopathological examination. On H&D staining, necrotic bone interspersed with the fungal hyphae is seen. The periodic acid skip stain showed numerous mucor hyphae as magenta pink colored aseptate hyphae branched at 90 degrees. Further, the necrotic bone showed the dead actinomycotic colonies interspersed within the trabecular surface. Candidal hyphae were also seen deep into the bone. Now, as we all know that Candida albicans is a normal inhabitant of the oral cavity, but under certain immunocompromised conditions, it becomes pathogenic. Now, let's see how COVID led to such devastating secondary infections. Now, in COVID, there is an immunosuppression due to decrease in CD4 plus T cells, CD8 plus T cells, B cells. There was also an increase of pro-inflammatory cell markers that led to the immunosuppression and rise in blood sugar levels. During the second wave of COVID, the Delta variant was common, which further targeted the islets of Langerhans, leading to the increased blood sugar levels. Based on the radiographic and the histopathological examination, a final diagnosis of mixed infections comprising of mucormycosis, actinomycosis, and candidiasis, also commonly known as black fungus, yellow fungus, and white fungus, leading to maxillary osteomyelitis was given. The patient was asked to keep his blood sugar under control and was administered posaconazole along with the oral clindamycin. Now, this case is intriguing because 3 infections were manifested in a single diabetic mellitus patient in a post-COVID phase. It was the first case published in the 2021. Now, let's see why there wasn't such a great extent of such various secondary infections in India during the COVID-19. During the COVID, there was an indiscriminate use of steroids leading to immunosuppression. During the second phase of COVID, there was an acute shortage of medical grade oxygen, which replaced by the industrial oxygen, which had some content of contamination. Use of humidifiers, high level of ferritin in COVID and diabetic mellitus patients was also one of the most important factors leading to such secondary infections. Therapeutic administration of zinc is also one of the most important factors. Concluding my case, I want to say that while steroids were considered to be a life-saving in this pandemic, they have proved to be a double-edged sword. The occurrence of oral infections, even after the remission period of COVID-19, signifies an alarming sign both for the patient and clinicians monitoring the oral health status during the follow-up period. Early diagnosis and treatment planning is mandatory to prevent the further complications. Thank you.
Now it's time for discussion. Over to you, Dr. Chittagong.
Yeah, it was a good presentation. Yeah, I just want to know what is the mode of transmission in this particular mucormycosis?
Ma'am, the mode of transmission was basically the aerosols and the direct contamination with the infected person.
So do you think it is contagious?
Yes, ma'am. To some extent, it is contagious.
So how do we diagnose it?
Ma'am, by the clinical examination, the black discoloration is one of the also the
No, diagnosis, confirmation.
confirmation might be histopathological examination. The HNDs. Yes, ma'am.
So how can we prevent this?
Ma'am, by proper immunization.
Okay.
It was an interesting case. My question is, have you done a follow-up?
Yes, ma'am, we have done a follow-up after the 3 months, but there was no recurrence and recurrence seen in the patient.
Okay. Can you name any other stain that demonstrate actinomyces organism better?
Sorry, ma'am.
So, thank you.
Thank you.
Thank you, judges. Now I would like to call UG paper 05. UG paper 05?
Yeah, just a second. Where's my laptop stuck? Can you see my screen? Is the screen visible?
No, ma'am.
Okay. Now, I can start?
Yes, ma'am, you can start now.
The global metamorphosis in nutrition patterns from periods of intermittent destitution, vigorous exercise, and malnutrition to a situation in which diet and physical activity patterns are one of the main drivers of non-contagious diseases have occurred. The shift in how we eat and drink, as well as energy imbalance, has led to soft drinks being one such product which has found its way into the diet of individuals. Soft drinks is a non-alcoholic beverage with natural or artificial sweeteners, caffeine, artificial taste, and juices. But there is an association between drinking soft drinks and a number of diseases like obesity, dental issues, bone abnormalities, and degrading the tooth enamel, causing dental caries or tooth erosion. But there is very little information on the possible risk due to lack of research on the distinctive characteristics or the harmful effects of these drinks caused by genotoxicity in the oral epithelium. So to understand this better, I conducted a study titled Evaluation of Genotoxic Effects of Soft Drinks in Oral Exfoliated Buccal Mucosal Cells, an in vitro observational study. Buccal mucosa was chosen because it acts as a first line of defense against carcinogens. It is capable of metabolizing carcinogens into reactive substances, and it also shows pathological alterations first before a systemic disease occurs. Aims and objective, it is aimed at providing a non-invasive, accurate, sensitive, practical, and in patient acceptable tool, and to quantify the frequency of micronuclei and exfoliated buccal cells and educating the public about the same. Methodology of the study, it was conducted on 3 cytological smears between the age group of 18 to 28, and they were divided equally on the basis of the soft drink consumption. The first group consisted of people who have consumed soft drinks for more than 2 years, and the second group consisted of those who have consumed for less than 2 years. Inclusion criteria were undergraduate and postgraduate students of the university, aged between 18 to 28 years of age. And exclusion criteria were patients with systemic diseases on medications known to cause changes in the oral epithelium and any recent surgery. Method, after a comprehensive case history, all patients were instructed to rinse their mouth thoroughly with saline. Cells were collected with the help of a wooden spatula with 5 to 6 unidirectional motions, spread out on a slide, and then stained with acridine orange. The micronucleus evaluation was first conducted under 10x and then 100x, and the number of micronuclei per 1,000 cells were calculated. These were the observations. We could see the presence of no micronuclei. Some indicated the presence of 1 micronuclei, 2 and even 4 micronucleus as well. Coming to the results confirmed that there was a statistically highly significant difference which was seen for the values. When compared on the basis of mean frequency of micronucleus, it was 2.4 for the first group and 0.4 for the second group. Independent sample t-test indicated that this difference was statistically significant. And when it was compared on the basis of mean percentage, independent sample t-test again revealed that the difference was statistically significant. These are the values. Coming to the discussion, studies conducted by Holland et al., Didburner et al. Stated that lifestyle factors like drinking alcohol, tobacco products, smoking cigarettes is thought to play a higher degree of nuclear anomalies in people who are exposed to other genotoxic substances. Like according to findings of a study conducted by Sali et al., genotoxic effects of cigarettes and hookah showed that the frequency of micronucleus was 8.3, which was quadruple of the current study. In a study conducted by Jindal et al., the mean frequency of micronucleus was 4.3, and soft drinks and alcohol consumption are known to create a synergistic effect which leads to an increased risk of carcinogenesis due to their genotoxic effects on the oral epithelium. So to conclude, the changes in our eating and drinking habits as well as energy imbalance has led to a compromised stability of our genome. Micronucleus is believed to cause is believed as a reliable sign of chromosomal instability, which is invariably present in precancerous cells. The current study has taken a step further to understand this better. Although there is currently a dearth of research about the genotoxic effects of soft drinks, this should not be a hindrance to the general public from receiving enough awareness regarding the negative impacts of soft drinks use on their health. Thank you. These are my references.
Thank you, ma'am. Now it's time for discussion. Over to you, Dr. Kevin, ma'am.
Yeah, it was a very good presentation.
Thank you, ma'am.
So what is your opinion? Should we include this soft drinks in carcinogens?
Ma'am, I don't think right now we can do that because there's just one step further in understanding if we could even see micronucleus in oral epithelium. I think we should go on to compare the frequency of soft drinks as well. That is one of the drawbacks of our studies, that we did not first consider the frequency which is there in each participant. So I think on the basis of that, I think then we can probably take it as one of the synergistic component which can cause carcinogenesis with other lifestyle changes like tobacco products or alcohol consumption.
So what is the norm? What is the accepted pathology associated with soft drinks?
Ma'am, there's dental caries, tooth erosion.
Okay, thank you.
It was a good presentation.
Thank you.
Age group included, which age group was included in the study?
Ma'am, 18 to 28 years of age.
Okay. Have you correlated micronuclear frequency with age?
No, ma'am, we didn't do it on the basis of age. We just did it on the basis of the number of years of consumption. Yeah. Thank you.
Thank you, judges. Now I would like to call UG paper 05. Sorry, UG paper 06. can start now.
Can I start?
Yeah.
Good afternoon to everyone present here. This is Aviga. She's 15. The only difference between her and any other teenage girl is that she's been dead for 9,000 years. And the main force behind her visual reconstruction is my topic for today. Forensic odontology, truth from a tooth. So forensic odontology is a branch of forensic science that uses the skill of the dentist to help bring the justice to the world. But for me, the interest started when I saw Sherlock Holmes deduce someone's whole biodata from dust under his cuticle. It's the law of detection and the thrill of the chase that made me choose this subject. Our aims and objectives to test the knowledge and attitude in forensic odontology of the dental community residing in the Navi Mumbai and Mumbai region. How we did this was by circulating an anonymous survey through Google Form filled with 12 questions, each targeted to match our aim, and a projected sample size of 300 dental clinicians and educators in the aforementioned area. This is my statistical analysis and correlation table. So our first questions were aimed at gauging the experience of the dentists, and we were happy to report quite the mixed bag with both years in the field and the nature of their work. How they maintain their dental records. Some maintained only digital, some maintained only manual, and around 50% maintained both. A shocking 47.4% had no idea what dental profiling was. How long can teeth survive after death? Everybody had a mixed answer, but it's 5,000 plus years. 72.9% had no idea how to categorize the different types of bite marks. 65.6% had no idea that you could even add identification marks in a prosthesis. So obviously 87.4% had never attempted the procedure. When asked if forensic odontology should be given more attention in the dental teaching curriculum, there was a positive response with 50% of people agreeing or strongly agreeing. Moving on to our discussion. Records must be maintained with a partiality to the digital kind, because manual records can easily be lost in a fire or misplaced by human error. The key role of record maintenance is in human identification by comparing ante-mortem and post-mortem scans. The picture of the tragic 9/11 terrorist attacks, where lives were lost and families broken. But to help provide closure, 596 bodies were identified by record comparison. Dental profiling is what helps in ante-mortem record collection, a triad to determine the ethnicity, age, and sex of a person from their tooth. What you see over here in the first picture is a homicide victim, discovered almost a year after her death in a waterbed frame. You can clearly see the damage done to her face, but even then the teeth remain in good condition and she was able to be identified by them. The answer in our study was 5,000 plus years for survival of teeth. What this means is, on top, the oldest primate tooth found, 10 million years old. In the bottom, the oldest human tooth found, 1.8 million years old. Bite marks are our dental fingerprint because every bite has a unique signature. Ted Bundy, a serial killer, over 30 women that he killed got justice when he was convicted with the help of a bite mark matching. Secondly, something closer to home, the tragic Nirbhaya case, where 2 of the 4 suspects were prosecuted through bite mark matching. Based on how convenient and cost-effective it is to add identification in a prosthesis, I was shocked not only to see the lack of awareness, but also the lack of addition in this subject. On dentures, there are a number of methods like adding barcodes or patient pictures. However, in modern prosthetics, implant identification is becoming most relevant, whereby using the new recognition software, the batch number of a highly resistant titanium implant can give you the complete manufacturing details for it. Basically, the lack of knowledge and awareness is poor, but there's a strong desire to inculcate this subject in our curriculum, which we should go ahead with if we form the newly proposed Dental Council of India system of 5.5 years. We already have enough doctors to stand up for the living. Let's find some to stand up for the dead. Thank you.
Thank you, ma'am. Now it's time for discussion. Over to you, Doctor.
It was a very good presentation. So you were telling about the importance of having dental documentation. So my question is, if the ante-mortem data are not available, what are the forensic application from tooth?
Yes, ma'am. So if there are no antemortem scans available, that's what the dental triad is for, to find out the age, the sex, and the profile of a person from their tooth. So if antemortem is not available, then you can use that method to find it.
How do you find
from the earlier?
How do we find the sex of a person from tooth?
There are many different things. The enamel rods are lesser in females.
Okay. What about
And
non-metric traits?
Yeah, we can use that also.
Okay, thank you.
It was a nice presentation. And what can we do for spreading awareness?
Ma'am, the problem with nowadays is only high profile cases get forensic odontologists. So I think that so the Dental Council of India has recently proposed that we change the curriculum time for dental school and increase it by half a year. So in that half a year, we should inculcate more forensic odontology courses so that people can properly understand, and every clinician should be able to at least identify and get the basic evidence started, because time is of the essence in cases like this. So I think that at a UG curriculum level, we should first make this change.
Okay, good. Thank you.
Thank you, judges. Now, I would like to call UG paper 07. UG paper 07.
Yeah,
I will show you some.
My screen visible?
You can start now.
What a nightmare. Bodies blackened, heads carbonized, shrunk and reduced to nothing, but only the teeth remained. Physical evidence cannot be intimidated. It does not forget. It sits there and waits to be detected, preserved, evaluated, and explained. Where traditional ways of visual recognition or fingerprint analysis fail, forensic odontology comes to the rescue in establishing the identity of an individual. The concept behind it is no two mouths are alike. In modern society, the crime graph is high, and mass casualties and large-scale disasters have caused a loss of human resources. Hence, the establishment of a person's individuality becomes important, and gender determination is a crucial step in the identification of an individual. This led me to choose the topic, determination of sex from human dental pulp and its reliability as a tool in forensic dentistry, a fluorescent microscopic study. This study uses tooth pulp tissue from extracted human teeth as a substratum for sex determination. The primary reason being its sequestered location. The second reason is its easy availability. Moreover, it is the preferred location for DNA extraction because of its greater quality of DNA compared with that of other dental structures. The present study is intended to expand current knowledge on the use of human dental pulp tissue as a significant tool of sex determination in forensic odontology. The primary objective of this study is to evaluate the presence of barred body in the histologically processed human dental pulp tissue taken from freshly extracted teeth using stains like H&E and Acridin orange. Secondly, to understand the reliability of tooth pulp in determining the sex of an individual. And finally, it will help in identification of an individual in forensic investigation. 48 patients, 24 females and 24 males were chosen. 3 groups were made on the basis of age, 15 to 30 years, 31 to 45 years, and 46 to 60 years. And the remaining armamentarium has been displayed. Only teeth extracted due to periodontal diseases, orthodontic purposes, and prophylactically extracted impacted third molars were included. Carious teeth involved in the pulp were excluded. In order to extirpate the pulp tissue, The tooth was longitudinally sectioned and was then split. The pulp tissue was separated of the pulp cavity with the help of needle and forceps. Serial sections with a thickness of 5 microns were taken and 2 different slides were prepared. One was stained with H&E stain and the other was stained with acridine orange. In the tissue stained with acridine orange stain, the cells with a bright fluorescent spot lying against the nuclear membrane were counted as Barr-body positive cells. And in the tissue stained with H&E stain, the cells with a purple spot lying against the nuclear membrane were counted as Barr-body positive cells. But these weren't very clearly appreciated. When the comparison of the number of Barr bodies among different age groups and different stains was done for females, it was seen that Barr bodies were visible better in acridine orange stain than in H&E stain. And between the groups, group 1, that is 15 to 30 years, showed a statistically highly significant difference. When the comparison of the number of Barr bodies among different age groups and different stains were done for males, it was seen that Barr bodies were visible better in acridine orange stain than in H&E stain. And between the group 1 showed a statistically significant difference. The fluorescent stain acridine orange has the advantage of being highly specific and accurate as reported by Khanna et al. They compared stains like hematoxylin and eosin, fluorine, and acridine orange for observing Barr bodies. Their results show that acridine orange proved to be a better stain than H&E stain in terms of inter-observer agreement. Reddy et al. In 2012 examined mucosal samples stained with acridine orange using for detection of Barr body positive cells. The authors found that female samples showed 18 to 72% cells showing Barr body positive cells, whereas males just showed 1 to 3%. The present study showed a similar correlation to the above-mentioned studies. The present study re-established the significance of dental pulp as an important tool of sex identification. The results showed that Barr bodies are predominantly found in females, and their occurrence decreases as the age increases. Thus, a conclusion was made that the observation of Barr bodies using fluorescent stains such as acridine orange could be a reliable, cost-effective, and a simple technique for the sex determination from human dental pulp of the teeth. These are my references. Thank you.
Thank you, ma'am. Over to you, Dr. Tikuna.
Yeah, it was an excellent presentation.
Thank you.
So I just want to know, have you done fixation before doing all these procedures?
Yeah.
How did you do?
This was stored first in 10% formalin, and then we had fixed the sample which was there.
And you underwent all kind of tissue processing?
Yeah.
For both H&E and
Sorry?
for both stain.
For H&E.
And what about acridine orange?
Acridine orange also dye was freshly prepared, and then the staining was done.
Okay, so your study says that your sex determination is more accurate with this acridine orange.
With acridine orange.
Where else you can find from tooth structure?
Sorry?
So you are done study on dental pulp. Where else from the tooth you can get this kind of thing?
Like Barr bodies?
Yeah, no, DNA. Okay, fine. Thank you.
So good presentation. Was it easy to identify Barr bodies?
Is it?
Was it easy to identify Barr bodies?
In acridine orange, yes, because the fluorescent spot was very distinctly visible at the periphery of the nucleus. But in H&E, it was slightly difficult to visualize it.
How many observers were there?
The participants were 48. 24 females and 24 males were chosen.
No, I was asking how many observers, how many people observed this? Only one observer was there? Or
One
more
observer.
than- Okay. Can you tell me any other markers for gender determination from DNA? Any other markers can be used?
The stains that can be used?
For gender determination from DNA?
There is quinine stain, which is used to detect Y chromosomes, F bodies in males.
Okay. Any other? Okay, thank you.
Thank you, ma'am. Next is UG paper 08. UG paper 08. UG paper 010. Sorry.
UG paper 010. UG paper 010. Can I start?
Yes, ma'am. You can start.
Share device on. Is my screen visible?
Yes, ma'am.
Hello. Yeah. My topic is pediatric geographic tongue, and it's actually a benign, chronic, reoccurring inflammatory condition of the oral cavity. It's of an unknown etiology. As per epidemiology concerns, it's like 1% to 2% of the world population are affected with geographic tongue, and it is also known as benign migratory glossitis, which is a chronic immune-mediated inflammatory illness. Clinically, it manifests as rhythmatous patches with a white margin that move across the tongue, and histologically, it forms neutrophilic microabscesses and epithelial edema. It's a benign inflammatory condition that most frequently occur on the tongue's dorsum and on the lateral side as well, and spread to the lateral edges. Multifocal, ciccinate, irregular rhythmatous patches surrounded by a slightly elevated keratotic band or line make up the distinctive appearance. The loss of the filiform papillae and thinning of the epithelium are represented by the rhythmatous patches. Regenerating filiform papillae and a combination of keratin and neutrophils make up the white border. Although the surface is not ulcerated, the loss of the surface keratin and papillae gives the impression that it is. They range in size from a few millimeters to several centimeters, and they are well-defined elliptical lesions. The label migratory refers to the fact that the location and the pattern change over time. The simultaneous epithelial desquamation at one place and growth at the another site are the causes of this apparent movement. There's this case that reported to the Department of Oral Medicine and Radiology, and it was a patient of 5-year-old, and he had this complaint of missing teeth. That is, the deciduous teeth were missing, like in the upper and the lower front region. The lateral incisors, the central incisors, and the canine, as well as the deciduous molars were missing. And during the intraoral examination, both the right and left maxillary mandibular deciduous incisors and canines, and both right and left mandibular deciduous molars were missing. And it was found that there was an early shedding of the primary teeth because the orthopantomogram showed the presence of the tooth buds of the permanent teeth. You can see the picture here where it's showing the absence of the teeth. And on further examination, it was noted that the patient has a geographic tongue and the parents were not aware of it at all. And the tongue had atrophic or debilitated patches on the dorsum or lateral border of the tongue. These patches are very smooth and reddish pink. Patient had no pain or discomfort whatsoever. The parents were asked about any past medical history related to it, and they were found that they basically had no idea that their child had this lesion. And they also it was also noted that the patient were having the skin lesions 2 years ago and were given a medication, topical medication, which is a combination of steroid and antifungal for it, and he got temporary relief after that.
Geography.
However, there was still on and off episodes of the infections. The picture below shows the post-inflammatory pigmentation that is present on the skin. There were another finding that was noted that the eyes of the patient were little bit bulging out. And so the blood tests were recommended to determine the thyroid stimulating hormone level, but the patient never reported back. And also to confirm whether the skin lesions are psoriasis or not, the appointment with the dermatology was also done, but the patient never went to that. And the patient was asymptomatic and geographic tongue is limited. So the only advice that we gave at this point to the patient is just to maintain the oral hygiene and take a lot of fluids, and no other medication was given as there was no symptoms. The Google literature Google literature only shows 12 cases of pediatric geographic tongue from the last 6 years. And it often developed throughout childhood and affect between 1 to 2.5% of the people worldwide. But the pediatric population has a prevalence that ranges from 0.37% to 14.3%. The sources are given below. Hello?
Continue your last 1 minute.
Can you, my presentation is almost done. You can ask me the questions. Hello.
It is a very good presentation. Can you give a common or the clinical DD for geographic tongue? Clinical differential diagnosis?
It can be lichen planus, and it can be erythroplakia, and yeah, these are the two that I know. Like aphthous also can be, but the most is erythroplakia and the lichen planus. That's the two I know.
So your patient was showing, multiple teeth were absent, yes or no?
Yes,
it's a premature exfoliation happened.
Yes, premature exfoliation.
So
of the
what could be the reason for that?
Well, we were expecting that it could be because of the thyroid, and we asked the patient to give us the report, but he never reported back. So we thought that it may be because of the thyroid hormone.
Okay.
Because it was showing the bulging of the eye also, so exophthalmos. So two conditions were there.
So the investigations were not done.
Yeah, we asked the patient to come back with the report, but never reported back to the department.
Okay, thank you.
So nice presentation. What all might be the causes or etiology of geographic tongue?
Well, the mostly the etiology is unknown. However, it has been reported that it is associated with the stress and it is hereditary. That's what the researchers have on the Google have said it, but how the etiology basically is unknown.
Okay, thank you.
Okay.
Thank you, judges. Next is UG paper 09. UG paper 09. Okay, I would like to call UG paper 11.
Hello, ma'am.
Yes.
ನೋಡ್ಕೊಂತೀನಿ ಬೇಡ ನೋಡೇ ನೋಡುತ್ತೆ.
UG paper 0 lab. Is my screen visible? Hello? Hello?
Okay.
Is my screen visible?
Yes, ma'am.
Can I start?
Yeah, you can start.
Good afternoon, everyone. My topic is osteoodontokeratoprosthesis, a tooth for an eye, a review. And blindness has been the most devastating condition of any individual. A combined oral and ocular procedure has evolved itself as a new vision through dentistry. The tooth for an eye surgery is the ideal treatment for patients with end-stage inflammatory corneal disease, where osteo means bone, odonto tooth, keratocornea, and prosthesis stands for artificial device and thus referred to as osteoodontokeratoprosthesis. Coming to the indications, it is bilateral corneal blindness in severe end-stage Stevens-Johnson syndrome, chemical burns, dry eyes, trachoma, and multiple corneal graft failures. And the contraindications include children under the age of 17, as there is high bone turnover rate and evidence of phthisis, advanced glaucoma, and irreparable retinal detachment. Now coming to what is the ideal keratoprosthesis. It should have improved optical quality with decreased abrasions and specifiable power. It should have excellent biointegration and should provide resistance against infection. And it should replicate some of the qualities of the cornea, such as drug penetration and allowing intraocular pressure movement. Now coming to the technique, the preoperative assessment include ophthalmic assessment as well as the oral cavity assessment. The ophthalmic assessment include examination of conjunctiva and cornea with determination of degree of dry eye, degree of vascularization, digital determination of intraocular pressure with A and B scans. Oral assessment include buccal mucosal assessment and dental assessment. If the buccal mucosal tissue is severely scarred, it may compromise the successful harvest. And if the patient is a smoker, it is advised to stop smoking to improve the chance of graft revascularization and to stop betel nut chewing to improve the tissue quality. And dental assessment include harvesting a tooth and it is associated alveolar bone for fashioning a dental lamina. Selected tooth should have healthy root, usually single-rooted tooth with good covering of alveolar bone. Adequate space between the tooth should be there, and overall hygiene, oral hygiene, and bone loss assessment should be examined using radiographic measures. The ideal tooth for the dental lamina is canine, and in the absence of canine, other single-rooted teeth can be used. The choice of upper or lower canine depends on the proximity of maxillary sinus in upper canine and the proximity of mental foramen in the lower canine. The patient must be given full information at this stage, such as the inevitable gap left in the dentition and the possible methods of management should be mentioned. And the psychological assessment is important as there is risk of psychopathology due to the past years of poor sight, expectations regarding sight and cosmosis, financial time and emotional stress, and it requires lifelong follow-up. Coming to the surgical technique, it is carried out in 2 stages. And in stage 1, the tooth is harvested to prepare osteoodontolamina. The root and surrounding jawbone is sliced sagittally until the pulp is exposed. After removal of the complete pulp, a hole is drilled through the dentin and the PMMS cylinder is cemented in place. The crown is removed prior to cementing the cylinder. The capra or the prosthesis is then implanted into the submuscular pouch under the eye for a period of 2 to 4 months. And this is how the oral cavity looks like after extracting the tooth along with the alveolar bone. And this picture shows the sagittal sectioning of the tooth along with the alveolar bone, and this shows the insertion of the optical cylinder into the osteoodontolamina. A full thickness next stage of the surgery is a full thickness mucoperiosteal flap from the buccal mucosa is harvested and the fat from the buccal mucous membrane is removed. Conjunctiva and tendons of the eye are separated from the underlying sclera. Removal of the corneal epithelium and Bowman's membrane of the eye. After that, suturing of the graft into the sclera. And the stage 2 of the surgery comes after 2 to 4 months. It includes retrieval of buried lamina from the eye and the reflection of buccal graft and exposure of cornea, followed by the trephination of cornea, removal of iris, and anterior vitrectomy is done after that. After that, lamina sutured and flap repositioned. Your last one. Coming to the complications, buccal mucosal graft site, there will be the graft harvested bed is left to degranulate. It is completed only after 2 to 4 weeks, and if there is excessive scarring, results in limited mouth opening. An alveolar graft site results in poor healing at the site, exposure of roots of adjacent teeth, damage to maxillary sinus. Breach of the maxillary sinus can be closed by advancing the surrounding mucosa, and if it remains patent, an obturator will be needed. To conclude, the OKP surgical technique has been practiced for the past 50 years. The creativity of using a tooth as an eye implant should hope to inspire future interprofessionals' approach to ophthalmic practice to provide the best care of patients. Thank you.
Thank you, ma'am.
Hello.
Over to you, Dr. Rekha.
Okay, it was a good presentation. No questions.
Yeah, it was a very good presentation. So sacrificing a tooth for betterness. So I just want to know at what age we are doing all these things?
Above 17 years.
Above 17 years.
Above 17 years.
And how long will it take?
About 2 to 4 months interval between the stage 1 and stage 2 surgeries. And it requires a lifelong follow-up, ma'am.
Okay, thank you.
Thank you, ma'am.
Over to you, Dr. Rekha.
It's over. I have asked.
Okay. Thank you, ma'am. Next is UG paper 1, 2, 12.
Am I audible?
Yes, ma'am.
Can I start now?
Okay, ma'am.
What your tongue says about your general health. Discolorations, bumps, patches on your tongue might be harmless, but sometimes they can give clue to what's going on your overall health. Good evening. I'm here to present an original research on the topic prevalence of physiologic melanin pigmentation on tongue. Coming to the introduction. In pathologic and physiologic conditions, chromatic variegations are observed in the human mucosal epithelium. Melanin is produced by the melanosomes of mature melanocyte. Melanocyte precursor cells from the neural crest migrate to the basal layers of epithelium and they become the mature melanocyte. So melanocytes are distributed with 30 to 40 keratinocytes, which forms as a unit, and melanin from the melanosomes are transferred to the keratinocytes. So the aim and objective of my study was to assess the frequency of melanin pigmentation on tongue among students in an institution. So the sample size was 300 students, 300 patients. I conducted a cross-sectional study in an institution among students of the institution. And the study period was 1 month and consent was obtained from the participants after describing the purpose of the study. So all the participants were interviewed about their medical histories and they were properly seated on a dental chair and examined under the mouth mirror with a dental chair light. And during the interview and oral examination, no participants were found to have any disease requiring treatment. So the site on tongue affecting oral melanin pigmentation, their age, sex were noted. So my results were, N was 300 patients and 90% of them were females and only 9.6% males were present. So 77.66% of them had physiologic melanin pigmentation on tongue and 22.3% of them did not have the pigmentation.
So the pattern of distribution, as I noted, was more on the anterior two-third with a percentage of 42, and then anterior and lateral surface with 32%, and the lesser was on lateral surface with 24%. The pattern of occurrence was single in 19% and multiple melanosis was noted in 48% and generalized melanosis was seen in 32%. So this seems the melanosis on tongue, the importance of melanosis on tongue comes when it gets associated with systemic diseases like Addison's disease, Peutz-Jeghers syndrome, neurofibromatosis, Albright syndrome, acanthosis nigricans, and also melanosis might increase in response to several drugs such as antimalarials like quinolones, antibiotics like minocycline. So, though it is clinically asymptomatic, this remains a matter of concern to rule out underlying malignancy like oral malignant melanoma. In many studies, it has been seen that the melanosis significantly increases as before the onset of the melanoma. So in our study, the overall prevalence of physiologic melanin pigmentation on tongue was 77.6%, which was most common on the anterior two-third, followed by anterior and lateral surface, followed by lateral surface alone. And multiple melanosis was noted. So here is a diagram showing melanosis on the anterior two-third. And here diffuse melanosis was noted on the involving the anterior and lateral surface. Here a single macule was noted on the anterior two-third and the melanosis as a cluster on the anterior two-third. So what can we do if a surface elevation or an increased pigment intensity is seen? Biopsy can be carried out to rule out the malignancy or any underlying condition. So physiologic tongue melanosis are treated for cosmetic reasons. Oral isotretinoin and carbon dioxide laser ablation are helpful management strategies. So coming to the conclusion, physiologic melanin pigmentation in my study was present in 77.6% of the participants, and the most common site of occurrence was anterior two-third and multiple melanosis was noted. And these are my references. And thank you.
Thank you, ma'am. Over to you, Dr.
Yeah, it was a very good presentation.
Thank you, ma'am.
So I want to know the clinical significance of doing this study.
Okay, ma'am. First thing is that the number of studies are less, and also now the people are giving more important for cosmetic purposes. So the treatment is undertaken for cosmetic reasons. When the melanosis is diffuse. So I conducted the study to know how prevalent the melanosis was among the students.
So do you think the melanosis is a physiological pigmentation?
Ma'am, the study group I took was devoid of any systemic diseases. So that I came to the conclusion that it was physiologic melanin pigmentation.
So what type of cosmetic treatment we give for this kind of patient?
Ma'am, laser treatments are done to reduce the intensity of the pigmentation.
So do you know something about post-inflammatory pigmentation?
Post-inflammatory, ma'am, not due to any underlying disease, like due to some tattoos or like that, side effects of medication.
Do we need to have a study like this for cosmetic treatment?
Ma'am, both are important. Like.
Okay, thank you.
Thank you, ma'am.
It was a good presentation.
Thank you, ma'am.
And my question is also on the importance of the study that you have answered. Okay.
Okay, ma'am. Thank you, ma'am.
Thank you, Tejas. Next is 13. 1-3.
Am I audible?
Yes, ma'am.
Good afternoon. I'm delighted to be here and presenting on the topic DNA methylation, squamous cell carcinoma, a review. Oral squamous cell carcinoma is the sixth most common malignancy in the world. It acquires 90% of all malignant lesions of the oral cavity. Early detection of oral squamous cell carcinoma is important to reduce the mortality rates and to help in prognosis. Oral squamous cell carcinoma is multifactorial, but the genotoxic agent that duly assigns are tobacco and alcohol. Human papillomavirus also plays a major role in the pathogenesis of the malignancy. The interaction of epigenetic factors and genotoxic agent may synergistically increase the risk of oral malignancy. Epigenetic changes are heritable modifications in gene expression without altering the DNA sequence. It does not change the DNA pattern, but it affects how the cells read genes. Three major types of epigenetic mechanisms are DNA methylation, histone modification, and ribonucleic acid interferences. Methylation is a common epigenetic mechanism that leads to progression of disease and also contributes to be the potential biomarker in oral squamous cell carcinoma. DNA methylation. It is a biological process by which a methyl group is added to the DNA sequence without altering it, but modifies the activity of DNA molecule by modifying the functions of the gene and affecting their expressions. This methyl group is added by DNA methyltransferases enzyme. DNA methylation involves a covalent transfer of the methyl group onto the fifth position of the cytosine ring with the help of DNA methyltransferases. And the family includes DNMT1, T2, 3A, and 3B. DNA methylation is a very important factor in embryogenesis, genomic imprinting, and preservation chromosome stability. But when dysregulated, it contributes to malignancy. When methyl group attaches to the gene promoter site, it typically acts to repress the gene transcription and acts towards tumor suppressor silencing. 98% of the DNA methylation takes place in CPG islands, and these CPG islands are located near a promoter gene. DNA methylation in oral carcinogenesis. The genes found hypermethylated in carcinomas include cell cycle controlling P16, P15, cell adhesion providing E-cadherin, DNA repairing HMLH1 gene. Genes that show promoter methylation in oral squamous cell carcinoma are those that participate in cell cycle regulation. PK16 gene, which is located on 9p21 chromosome, which is usually identified as a tumor suppressor gene, but it's methylated in oral squamous cell carcinoma. And this alteration of the gene affects the cell cycle, leading to tumor progression. E-cadherin, which is involved in the formation of adhesive junction in epithelial cells, but its absence is linked to the alteration in cell functions and metastasis. Therefore, low expression of E-cadherin contributes for an aggressive behavior of oral squamous cell carcinoma. Genes such as HMLH1 contributes to DNA damage repair, but it is seen constantly renewed cells such as epithelial cells of the oral mucosa. Silencing of this gene will also facilitate malignancy. Epigenetic therapy in oral squamous cell carcinoma. The aim is to reverse the epigenetic aberration. DNA methylation inhibitors were the first epigenetic drug to be used. This drug induces growth inhibition in cancer cells by activating the tumor suppressor. Inhibitors, they are 5-acetylcytidine, 2-deoxy-5-acetylcytidine, which is also known as decitabine. Conclusion. Oral carcinogenesis is a multifactorial process that can alter the function of oncogenes and tumor suppressor genes. The determination of promoter methylation status is useful for identifying the tumor cells in patients at risk of oral squamous cell carcinoma. Overexpression of the tumor suppressor gene are related to carcinogenesis, as new anti-cancer drugs have been used as demethylating agents. Thank you.
Thank you, ma'am.
Yeah, it was a very good presentation. You were talking about DNA methylation and all. So what is the role of P53?
Is that an apoptosis related one which is usually involved in cell cycling?
Okay.
It was a nice presentation. Okay, thank you.
Thank you.
Thank you, ma'am. Next is UG paper 14.
Yes, ma'am. Shall I start?
Yes, ma'am. You can start.
Good afternoon, everyone. The topic for my paper presentation is transcription practice of the patient's rescue, an immunohistochemical study using OCT4 in oral submucous fibrosis. With profound significance to alleviate many diseases, stem cells have shown a dramatic rise in literature in the medical field in recent years. Stem cells are special human body cells that have the ability to develop into different cell ranges, for example, embryonic stem cells and adult stem cells. Oral malignancy adds up to 1/4 of the tumors happening around the world. Squamous cell carcinoma being the most well-known, trained by conceivably dangerous problems, for example, oral submucous fibrosis, leukoplakia, and so on. This investigation will be centered on one such potentially malignant disorder, which is OSMF. Being a habitual lesion, it has been demonstrated to be related to tobacco biting, betel quid biting, and so on. OCT4, that is, octamer binding transcriptase factor 4, also known as POU5F1, is a hemodomain transcriptase factor of the POU family. Its expression is critically involved in the self-renewal of undifferentiated embryonic stem cells. Its role in reprogramming is used to create induced pluripotent stem cells along with SOX2, KH4, CMYC, and so on, which have been studied by various researchers. As we know, there have been various studies which describe these transformations as a potential marker for malignancy, but very few studies have been done that describe the transformation from pre-malignant to malignant disorder. So this study mainly focuses on the transformation, which is the lacunae that have been found in all the other studies. The aim of this study is to evaluate the immunohistochemical expression of OCT4 in oral submucous fibrosis and to show an uptake on various histopathological diagnosed cases of OSM leading to early diagnosis and early cure. The study sample consisted of 40 specimens, out of which 30 specimens are of oral submucous fibrosis and 10 specimens are of oral was of normal buccal mucus as a control group. Inclusion criteria consisted of histopathologically diagnosed cases of OSMF given by Khanna, Jain, and Andrat in the year 1995, which was classified as very early, moderately advanced, and advanced. Exclusion criteria consisted of patients suffering from immunodeficiency syndrome or hematological systemic disorders, frictional keratosis, and other oral lesions, for example, oral lichen planus. Since it's an ongoing study, therefore, the patient sample size was limited to 30 patients, and the cases were taken abiding to all the above following criteria. The study was a double-blinded study wherein 3 observers who were totally unrelated to the study were involved. The graphs here show the comparison of the histological staging by different observers and the clinical staging using Chi test. The last graph and the adjacent table shows the comparison of histological staging by the observers, which was analyzed using SPSS software, showed insignificant results with a p-value greater than 0.05. The stain secretions for the IHC counterpart. This marker named OCT4 has a specific function which includes ability in tumorigenicity, tumor metastasis, and distant reoccurrence after chemo in different types of cancer. This marker shows an uptake in downregulation of MIR145 by aeroclean, which is the main constituent of ericanat, as a result of which EMT occurs. The exposed epithelial cells thus acquire increased chemoresistance, augmented migration, and increased invasiveness. Decreased stem cell maintenance results in decreased hypoxic environment created due to collagen fibers and increased vascularity, which results in increased stem cell hypoplasia, leading to increased epithelial atrophy and increased loss of retipex. The study mainly focuses on the from pre-malignant to malignant lesion, and thus a challenging study where we take up only the pre-malignant lesion, which is OSMF. Though the results obtained from this study do not show any contingency between OCT4 marker and OSMF,
Then your last one.
But with no number of patient samples, we hope to find a change that could make a patient's life matter. These are my references. Thank you.
Thank you, ma'am. Over to you, Dr. Tibi, ma'am.
I think your slides were moving. I think your slides weren't moving. Okay. Anyway, so what is the etiology of submucous fibrosis?
Yes, ma'am, I can't hear you clearly.
What is the etiological factor for submucous fibrosis?
Ma'am, it is erica nut, which is the mainly constituent of nicotine or erica nut. Most common is erica nut, which results in OSMF, and even PP elevation is mainly affected because of the spicy food.
You are done the study? You yourself done the study?
Yes, ma'am. Yes, ma'am.
Where did you study?
Ma'am, in my own college.
In your own institution?
Yes, ma'am.
Okay, so what was your negative control?
Ma'am, normal buccal, as a control group, we had normal buccal mucosa. 10 patients with normal buccal mucosa as a control group.
So do you think that in normal epithelium, you will have a same regulation like OSMF?
No, ma'am. It histopathologically, they will be different.
No, I'm asking about IHC. I'm asking about the marker.
Yes, ma'am. No,
So
ma'am.
do you think that in normal epithelium, this will be absent, this marker?
Yes, ma'am. It won't.
Okay, thank you.
Thank you.
Okay, in your presentation, the slides weren't moving. So,
I'm sorry, ma'am. It must be due to some.
okay, must be due to some problem. Okay. So, can you name some EMT inducing transcription factors?
Transcription factors.
Okay. Thank you.
Sorry, thank you.
You will also appear on the screen.
Thank you, judges. Now I would like to call UG paper 01.
Morning, ma'am. Good afternoon, ma'am. My topic is whether caries can be combated by coffee. Can you hear me, ma'am?
UG paper 01, kindly share your screen.
Is it okay, ma'am? Ma'am? Ma'am, can I start the presentation?
Yes, you can. You can share your.
Yes, you can start.
So good afternoon. My topic is whether coffee can combat caries. So as we know, oral microflora is crucial in the initiation and progression of caries. An important strategy in the prevention of dental caries is to inhibit the Streptococcus mutans caries causing bacteria, and use of natural products in disease prevention has been increasing recently. One among such products which has anti-cariogenic properties against S mutants is coffee. So the aim of this paper is to evaluate the anti-cariogenic efficacy of coffee against S mutants. Often dentists advise against drinking coffee. They refer to those sugars, creams, and tannins that cause discoloration, weakens enamel, and makes it more prone to cavities. But new research has occurred too and has given many dentists a wake-up call to this caffeinated drinks benefits. Now let's break the ice with a cup of coffee. Coffee is a darkly colored, bitter, and slightly acidic drink prepared from roasted coffee beans. Sugar substitutes, milk, and cream are often used to mask the bitter taste or enhance its flavor. Now, the biochemical components of coffee in a 100 ml cup is shown here. Basically, it consists of fibers, trigonolin, trichlorogenic acids, and mainly caffeine. Now, the banes of coffee. Coffee is often associated with staining of teeth, and it's due to presence of polyphenol, which breaks down in water, sticks to teeth, imparting yellow hue to the teeth. Drinking a large amount of coffee on a regular basis is often associated with breakdown of enamel and sensitivity problems. A lot of coffee consumption lead to bad breath rather than coffee breath, and it's counterintuitive because even though it's a drink, it can often cause drying of mouth by inhibiting saliva production. It also often increases the consumption of sugar, can cause tooth decay. Now, the boons of coffee. Believe it or not, black coffee has proven to protect your teeth from cavities. Studies reveal that persons who drink an average of 3 cups.
Excuse me, have you shared your screen?
Yes, ma'am.
Okay.
Ma'am, is it okay? Ma'am, is it okay?
No, you haven't started sharing the screen. You haven't started sharing the screen.
UG paper 01. If you can't share right now, we will call you after later.
Okay, ma'am.
Okay, next I would like to call UG paper 02.
Yes, ma'am. Is it visible, ma'am?
Yes.
Ma'am, very good afternoon to you, ma'am. I'm going to present a topic on case report spindle cell carcinoma. Introduction: spindle cell carcinoma, otherwise called as sarcomatoid carcinoma, is an uncommon biphasic aggressive neoplasm exhibiting high mortality.
Please share your screen.
Is it now visible, ma'am? Is it visible now, ma'am?
Yes, ma'am. You can start now.
Introduction. Spindle cell carcinoma, otherwise called as sarcomatide carcinoma, is an uncommon five-phase aggressive neoplasm exhibiting high mortality rate. The WHO recognizes spindle cell carcinoma as a variant of squamous cell carcinoma and includes the term sarcomatide squamous cell carcinoma. And it is a rare entity which comprises about less than 1% of all oral cavity tumors. I'm going to present a case which reported to our institution. A 72-year-old female patient presented with a chief complaint of ulcer in the right lower back tooth region for past 1 month. The pain was continuous, aggravated on mastication. The patient had a history of hypertension and wheezing for past 3 years, and she is under medication. The patient did not have any previous history of pre-existing squamous cell carcinoma or radiation therapy. External examination reveals there was no facial asymmetry and there was no external swelling or growth, and there was no spinous fistula. Internal examination inspection, the lesion revealed ulcerative growth in the right lower back tooth region, which is grayish white in color with pigmentations in the buccal mucosa and lower lip. The ulcer was measuring about 3 × 2 centimeter and which was oval in shape. On palpation, it was tender and firm in consistency, and there was no lymph node involved. The provisional diagnosis what we gave was a malignant ulcer in the right buccal region. The differential diagnosis was the ulcer secondary to deep fungal infection. What we suggested is OPG. So OPG reveals deep proximal forehead with lytic areas of bone destruction noted in the periapical region of forehead with permeative pattern along with resorption of mesial distal root apex. Histopathological findings. The histopathological findings shows stratified squamous epithelium with a neoplasm arising from it and infiltrating the subepithelial tissues in sheaths and fascicles. The tumor cells are predominantly there is high nuclear cytoplasmic ratio. There are highly pleomorphic mitotically active nuclei present with condensed chromatin and conspicuous nuclei present. There is desmoplasia and dense cell filtration by lymphocytes, neutrophils, and plasma cells. The histopathologic impression was spindle cell carcinoma. We suggested IHC to confirm the diagnosis. Immunohistochemistry was done to further confirm the diagnosis and further treatment plan. The tumor cells were positive for P40. P40 marker, which has high sensitivity and specificity for squamous cell carcinoma. And to rule out other sarcomas, we use P40 marker. Final diagnosis, it was spindle cell carcinoma, and the treatment involves combination of surgery and radiotherapy. The discussion part, the WHO defines this tumor as carcinoma within which there are some elements resembling squamous cell carcinoma that are associated with spindle cell component. This tumor is otherwise called as perlesion tumor, carcinosarcoma, sarcomatous carcinoma, pseudosarcomatous carcinoma. And in the head and neck region, most commonly seen in larynx and oral cavity. In the oral cavity, it has a side predilection for lower lip, tongue, alveolar ridge, gingival mucosa, and buccal mucosa. In our case, the lesion is seen in the buccal mucosa. The majority of spindle cell carcinoma cases occur in men in 6 to 8 decades of life. In my case, the patient was female who was 72 years old. It is also associated with several risk factors like cigarette smoking, alcohol abuse, and previous radiation exposure to the affected area. In contradictory, in my case, the patient has no history of oral habits or a history of previous radiation exposure. SPC clinically exhibits extensive ulceration. In our case, it was ulcerative proliferative growth and it was very painful. The tumor grows very rapidly and early metastasis is very common. The 5-year survival rate of oral spindle cell carcinoma is 30%. The clinical TNM staging and superficial and invasive findings influence the effectiveness of surgical treatment. The TNM staging was done, it was T2N0M0. And in our case, there was no nodal involvement and the patient was referred to PET scan, but it was further under onco department for diagnosis. Histologically, pathologists believe 2 separate neoplasm clones combined to one lesion and attributed to collision tumor. The sarcoma components were believed to be an atypical stromal reaction. Recent evidence is that spindle cell component represents divergent differentiation with a monoclonal origin from a single stem cell. In our case, the SPCC component exhibits both epithelial cells and the spindle cells. And immunohistochemistry, the other markers used are AE1/AE3 and pancytokeratin epithelial membrane antigen in P63. With use of IHC, it is possible to exclude from other diagnoses like sarcomas, leiomyosarcoma, malignant melanoma, rhabdomyosarcoma, nodal fasciitis, peripheral nerve sheath tumor. Conclusion, hereby I conclude that Spindle cell carcinoma is an extremely aggressive neoplasm presents with heterogeneous pathological features, clinical behavior, and prognosis, and there's a need for prompt diagnosis. With recent advances in investigatory methods, the delay in initiating the treatment could be avoided to increase the survival rate and to reduce the morbidity and mortality. Thank you, and these are my references.
Thank you, ma'am. Over to you, Dr. Shah. Jigana.
Yeah, it was a good presentation.
Thank you, ma'am.
So have you done any mesenchymal markers?
I've done money P40 marker, ma'am.
So with that only you concluded the spindle cell carcinoma.
Yes, ma'am. Yes, ma'am.
So when do we doubt normally spindle cell carcinoma histopathologically?
It is entity with two dual cells like epithelioid and spindle cells will be present, mesenchymal cells. If both are present, sometimes we have a difficult to identify what it could be.
So we don't need to exclude other markers, other lesions.
We have to exclude other lesions. P40 has a high sensitivity and specificity for squamous cell carcinoma. And to rule out other sarcomas, I use P40 to other differential diagnosis.
Okay, thank you.
It was a good presentation. Have you included only one case or more number of cases were there?
I included one case. Actually, it was a case C this month.
Okay.
2 cases was there, but after IHC, the other case was negative, ma'am. Which we include other panel of markers to confirm it, ma'am.
Oh, okay, okay. Okay, good. Thank you.
Thank you, ma'am.
Thank you, judges. Now, I would like to call UG paper 08. It's a last call, UG paper 08.
Hello, ma'am.
Yes, you can share your screen.
Okay, ma'am.
You can start now.
I'm audible. Hello, ma'am. Am I audible?
Yes, ma'am.
Can you see my screen, ma'am?
Yes, ma'am. You can start now.
The good physician treats the disease. The great physician treats the patient who has the disease. William Osler. Good afternoon, everyone. Today, I am going to present a case report, COVID-19 infection triggered vesicular bullous lesion of oral cavity. So my case report is of a 65-year-old female patient who come to our department showing multiple recurring ulcers in the mouth with difficulty in swallowing since 6 months, and his medical history includes chickenpox 30 years back and history of COVID-19 infection 6 months back and history of lip ulceration since many years. On general examination, it is moderately built and nourished, and there is facial asymmetry, pallor present and no itchiness, clipping is absent, and also edema is absent, and vital signs are all normal, and extraordinarily there is palpable and tender right and left submanual lymph nodes. On intraoral examination, there is tender multiple well circumscribed erythematous ulcerated lesions, and bilateral buccal mucosa, tongue, lips, soft palate, lateral border, and tip of the tongue are affected, covered by pseudomembrane with erythematous surrounding, flaccid bullae, ventral aspect of the tongue. And there is no abnormality dictated on hematological test, upper GI endoscopy, and CT thorax. Investigations is of immunoglobulin, patient tested for HSV antibody, and also, and there is round multiple ulcers of size 2 into 2 mm on tip and left lateral border of the tongue, lower labial mucosa and gingiva, left retromolar trigone, and lesions erythematous with pseudomembrane slow, severe tenderness. And elevated IgG, multiple ulcers, tongue, and mucosa, COVID 6 months back, and treatment given was tab acyclovir 40 mg for 1 week and cap omaze and metrozil for 1 week. And on second visit, there is symptomatic with multiple ulcers, peeling of mucosa, lower and upper vestibular, labial and buccal mucosa and soft palate, difficulty in chewing and swallowing. Right and left buccal mucosa shows around areas with necrotic slows. Patient did not respond to assertive and presence of mucosal peeling in the mouth, and differential diagnosis of autoimmune vesicular bullous lesion. Cytology examination has been done. On histopathological examination, there is hypoplastic parakidney stratified squamous surface epithelium, suprabasal split, connective tissue bases as arranged in tombstone pattern, and areosplit split acantholytic cells, and it is suggestive of pemphigus vulgaris. Post-treatment picture is given, and we given the tab bisolone 10 mg OD for 10 days and cap omaze and metrozole, candid gum paste. Now, how COVID-19 trigger autoimmune vesicular bullous lesion? In that, the mechanism is in the autoimmunity, molecular mimicry, bystander activation, and expansion of autoreactive T cells by the epitope spreading phenomenon. Take-home message is emerging pathology. 4 cases has been reported till now, and general practitioners and oral should be more aware of COVID-19 triggered lesions in the oral cavity. These are my references. Thank you.
Thank you, ma'am. Over to Dr. Utika.
It was a nice presentation. So
thank you, ma'am.
Let me ask you, why do you want to correlate this particular vesicular bullous lesion with COVID-19?
Ma'am, why? Because the vesicular bullous lesion is of immunity-related disease, and also when COVID is also due to some immune-related conditions. But because after COVID, there is a reduction there, and there is alteration in the immunity, and it can lead to trigger them vesicular bullous lesion.
So we should include in post-COVID complication vesicular bullous lesions?
Yes, ma'am.
Okay, you said that you have done exfoliative cytology, right? You have shown the slide also.
Yes, ma'am.
How did you do that?
Ma'am, superficial cells have been scraped off and
from where? From where you are taken?
Ma'am, from the tongue and buccal mucosa.
Okay, thank you.
Thank you, ma'am.
Okay, it was a good presentation. Which are the typical cells seen in pemphigus?
Ma'am, SANG cells.
Have you noted any SANG cells in the cytology smear?
Yes, ma'am.
Okay. Okay, thank you.
Thank you.
Thank you, judges. Next is UG paper 09.
Yes, ma'am.
Okay.
Ma'am, can you see my screen?
Yes,
Good afternoon, everyone. As rightly quoted by Buddha, health is the greatest gift, contentment, the greatest self, faithfulness, and the best relationship. Today, I present before you the topic cystic aorta, the master of disguise. Here, we present the case report of an 18-year-old male patient who came with a swelling and pain on the left side of the face since 4 to 5 months. And the swelling was progressively increasing in size, and a typical straw-colored fluid occasionally exuded from the swelling. On clinical examination, it was noticed that the swelling was circular with a size of about 5 into 3 centimeter, and it was located in relation to 2-3 and 2-4. When a radiography was taken, CBCT demonstrated well-defined radiolucent lesion between the roots of 2-3 and 2-4, and it also showed the displacement of the root of adjacent tooth. An excisional biopsy was done, and it showed a brown-colored firm consistency specimen. Now, a provisional diagnosis based on all these clinical features was done, and it was, sorry, ma'am. A provisional diagnosis was done based on all these clinical features, and it was diagnosed to be lateral periodontal cyst initially. And the differential diagnosis include dentator cyst and globular maxillary cyst. But a histopathological examination was done, which revealed a fibrovascular connective tissue exhibiting an autogenic epithelium, which proliferates into the lumen as interconnecting strands and solid areas. And there were also many areas of extravasated RBCs. We can also see the presence of spindle-shaped, cuboidal, and columnar cells in a variety of pattern of scanty fibrous stroma, and there were also areas of concentric calcifications. And the ducts, which is present in this histopathological examination, was lined by cuboidal epithelium, and it also had an eosinophilic rim, which is called as hyaline ring. So based on this histopathological diagnosis, it was finally diagnosed, the condition was finally diagnosed to be cystic adenomatoid automogenic tumor. So the cystic presentation of AOT was first reported in 1915, and back then the literature told that AOT was associated with dentigerous cyst. But later on, the further studies showed that there was an absence of impacted tooth, so therefore AOT was not related to dentigerous cyst. Now, this tumor is commonly called as a two-third tumor because it showed two-third cases of maxilla. Two-third was seen in young females. Two-third cases of the cases was related to an unerupted tooth, and two-third was related to canines. Kumar et al. Claimed that AOT was not actually a tumor, but the cyst was actually exhibiting hematomatous intraluminal proliferation of the epithelial cells, which is derived from HERS. So based on all this clinical location and radiographic and histological, it was finally diagnosed the patient was having extrafollicular variety of cystic AOT. Now, extrafollicular type constitutes about 24% of the AOT, and it has been subdivided into 4 types. E1, there is a tumor has no relation to the tooth structure, either erupted or unerupted. E2, it causes intraradicular adjacent roots to diverge apically because of expansion. E3 is superimposed on root apex, and E4, the tumor is superimposed on the midroot level. Now, in our case, it was E2. Now, there is a very big debate for this extrafollicular AOT, whether it is a tooth cystic lesion or it is a result of cystic degeneration. Thank you.
Thank you, ma'am.
So it was a good presentation.
Thank you, ma'am.
So was there any impacted tooth associated?
No, ma'am. It was finally diagnosed to be an extrafollicular type of AOT.
I'm asking, radiographically there was no impacted tooth, right?
No, ma'am.
Okay. So why do we call this adenomatoid odontogenic tumor as an odontogenic hamartoma?
It was considered to be an hamartoma because of its limited size.
Okay. So you are done the follow-up with this particular patient?
Yes, ma'am. The recurrence rate was low. The patient did not, there was no recurrence observed.
Okay, thank you.
Thank you, ma'am.
It was a good presentation. So
Thank you.
which are the common types of AOT?
There are mainly 3 types of AOT, follicular, extrafollicular, and peripheral.
So this one is an extrafollicular range.
Yes, ma'am.
Right? Right.
Yes, ma'am.
Okay. Okay. Thank you.
Thank you.
Thank you, judges. Again, I would like to call UG paper 01.
Good afternoon, ma'am.
UG paper 01, we can share your screen.
Good afternoon, ma'am. My topic is whether coffee can combat caries. As we know, oral microflora is crucial in incision and progression of caries. An important strategy in prevention of dental caries is to inhibit Streptococcus mutans, which is a caries-causing bacteria. And use of natural products in disease prevention has been increasing recently. One among such products is coffee, which has anti-cariogenic properties against S mutants. The aim of this paper presentation is to evaluate the anti-cariogenic efficacy of coffee against S mutants. Often when dentists advise against drinking coffee constantly, they refer to those sugars, creams, and tannins which cause discolorations, weakens the enamel, and make it more prone to cavities. New research has occurred too and has given many dentists a wake-up call about the benefits of caffeinated drinks. Let's break the ice with a cup of coffee. Coffee is basically a darkly colored, bitter, and slightly acidic drink prepared from roasted
Ma'am,
coffee
your slide
beans.
is not moving.
Ma'am, I'm moving it. Ma'am. Ma'am? Ma'am, is it okay?
No, the slides are not moving.
Yes.
You can start now.
So coffee is a darkly colored, bitter, and slightly acidic drink prepared from roasted coffee beans. Sugar, sugar substitutes, and milk and cream are often used to mask the bitter taste or enhance its flavor. Now, the biochemical components of coffee in a 100 ml cup. Basically, it contains protein, soluble fibers, trigonelline, chlorogenic acids, minerals, niacin, melanogens, volatiles, and most importantly, caffeine. Beans of coffee. Coffee is often associated with staining of teeth, which is due to the presence of polyphenol, which breaks down in water and sticks to teeth, imparting a yellow hue to teeth. It also is associated with breakdown of enamel, cause sensitivity problems. A lot of coffee consumption can lead to bad breath rather than coffee breath. And it may sound counterintuitive because coffee is a drink, but it could have drying effects because it inhibits saliva production. Increased coffee intake, increased consumption of sugar too, and hence may lead to cavities. Now the boons, believe it or not, black coffee has now proven to protect your teeth from cavities. Studies reveal that people who drink an average of 3 cups of black tea daily might have fewer cavities than those who don't drink coffee. Now, the studies on effect of coffee in caries occurrence. According to Ferdias in 1995, volatile and non-volatile organic acids like chlorogenic acid and caffeic acid with phenols and aromatic compounds are components of green coffee shown to have antibacterial effects against pathogenic bacteria. Dagley et al. In 2002 found out that green and roasted coffee solutions interfere as mutants adherence to saliva, coated hydroxyapatite beads, anti-adhesive properties together with bactericidal effects on S mutants have anti-karyogenic role of green coffee. Now, Walter's Kluwer, coffee made from roasted coffee beans has antibacterial activities against certain microorganisms. Inhibition of coffee, and tea is due to the gelatin precipitating tannins and partly to the components that exhibit properties of monomeric polyphenols. Antonio et al. In 2011 stated antibacterial activity of... Yes, okay. Antibacterial activity of coffee against S mutant changes according to chemical combustion that's influenced by the species and processing of coffee. Coffea canifora extract presented better performance as an antibacterial agent compared to Coffea arabica. Payne et al. In 2012 said green coffee bean extract in particular has received special attention due to presence of antimicrobial action against gram-positive, gram-negative bacteria. Meckelberg et al. Revealed that inhibitory action of coffee camphora against dental biofilm. Nontak et al. In 2015 proposed antibacterial activity of caffeine in green tea extract is attributed to its ability to pass easily through the bacterial cell wall and starts to inhibit bacterial DNA synthesis. Lamiak Hedam Baker in 2017 said both green and Arabica coffee solution shows inhibitory action on growing S
Ma'am,
mutants.
your time is up. Now over to you, Dr. Tibin, ma'am.
Okay, it was a good presentation.
Thank you, ma'am.
So what is your opinion? Should we take or not coffee?
Yes, we should consider it as
so you're
a
giving
method of
contradictory statement. We should not take. It is causing caries. It is having
Ma'am,
many bad effects. But you are telling again, studies are telling that it is good. So should we take or not?
Ma'am, the conventional belief is that we shouldn't take coffee because it causes staining. There is more of enamel erosion and all. But newer research says that it should be taken. But better, you should not add this sugars, creams and all. Coffee in its raw form, you make black coffee, then that is actually preventing caries.
Okay. Okay, thank you.
Good presentation. Which component of coffee is anti-cariogenic? Which component do you think is anti-cariogenic?
Polyphenols.
Okay. What is the role of tannic acid?
Tannic acid, ma'am, it's good feature.
Any future applications?
Ma'am, it can be used in making toothpaste, chewing gums, etc. because it has a good flavor as well as it can reduce caries.
Okay, thank you.
Thank you, ma'am.
Thank you, judges and fellow participants, for your cooperation. Now, I would like to call Dr. Tibin K. Baby. Ma'am,
Yeah.
kindly receive the certificate as a token of appreciation. Okay.
Yeah, thank you.
Thank you so much for the invite, Dr. Sunil sir and team.
Thank you all once again. We are winding up the session. Thank you.